So usually it's a physiological self-limiting cause which will be transient, which will improve over that and it will be there. Otherwise, unilateral testis, we will see a lot of them who are persisting. That is non-endocrine usually. And then if you have a bilateral, you have to start thinking of a possibility whether there is any endocrine disorder from that regard. So we'll touch how do you manage. Again, this is based upon the European Society. What they say, surgery. So either you remove it or bring it to the scrotum. So if you feel that the neurovascular bundle is big enough, they will bring it to the scrotum. Otherwise, they might have to remove it. Now, very importantly, any palpable testis, you do usually a inguinal approach. If it's a non-palpable, you have to go via a laparoscopic or an abdominal approach. Now, orchidopexy of 12 months and latest by 18 months. So there is a bit of discrepancy. The Americans were more aggressive. They said 6 months, you send to the surgeon. Here they are saying Europeans are always more conservative, 12 months, 18 months. But I would say 12 months is the most acceptable range when you should not delay beyond that in that regards. Everybody thinks, so again, not in a guidelines means it's being used a lot. So what they're saying is that do not give them hormonal therapy, adjuvant or neoadjuvant. What is neoadjuvant? Alapan?
Some chemicals can be before.
Yes. So like in breast carcinoma, you give chemotherapy to reduce the size. So it's not recommended. So HCG before surgery and all those things is not recommended. Bilateral testing, this is the interesting scenario, offer endocrine treatment to possibly improve further potential. What they are silent about is that they are talking about both HCG and HMG. So what they're talking about is that they're talking about a hypogonadotropic hypogonadism situation, and that theoretically you can use LH and FSH both to get that response. And in a post-pubertal, again discussed this, I've already discussed about removal. What about the American guidelines? Very importantly, they again say do not use hormonal therapy. So this is one thing which is very, very clear, that you should not use HCG. If there's one message from this talk, is that you should not use HCG in the treatment. In the absence of spontaneous descent by 6 months, they would say refer for surgery. Definitely in prepubertal boys with palpable cryptorchid testis, you have to do a orchidopexy, and again non-abdominal, you should do it from the abdominal location, which becomes important. So just to summarize, if you have a neonate with bilateral non-palpable testis, immediate workup is required to exclude XXDSD. If you have bilateral non-palpable testis beyond the neonatal period and your AMH is detectable, immediate referral is required. If you have unilateral palpable testis or a non-palpable testis after 4 before 1 year, refer for orchidopexy. If it's acquired, you need to refer it immediately. So you need to understand which are the red herrings that you need to worry about and concern. If it's an atrophic testis also, it's a waste of time. Refer immediately in that regards. Now, medical therapy has got limited/no role. Possibly bilateral fertility, as the American Association was talking about. The agent is HCG, GnRH, HMG, all that, but we don't often use it. Essentially, there may be an adverse effect of some early puberty-like changes, scrotal erythema, which you can identify in that regards. It's not a very effective therapy. You may have 20% chance of descent, and very importantly, it's not going to be very, very effective. The goal of surgery is to achieve a normal location, removal of extra tissue. The benefit is that the trauma torsion becomes less, fertility chances improve, and the risk of malignancy, you can identify that at an early stage. Timing after 4 months, you should consider, and latest by 12 months. So these are the two messages. Do not wait and watch beyond 12 months, and do not use too much of medical therapy in terms of evaluation. Now, for orchidopexy, the procedure is to free the testis and cord, move to scrotum and sutured, usually inguinal or scrotal is one preferred. Normal testicular size is important, and you need to have a neurovascular bundle. And follow-up is to be done for secondary descent and local infections from that regards. Now, you may also need to do an exploration if you have a non-palpable testis, especially if it's bilateral with a detectable AMH. You need to go for exploration, laparoscopic one, and the procedure is to remove the atrophic tissue because you cannot really bring it down in that regard. So if you have abdominal testis, you have to remove it. Again, a big message, do not routinely do an MRI. And other things is not going to do much help in that perspective. Now, there is a chance of recurrence of the scenario in around 10% cases. Fertility may be compromised if you have a later procedure. If you have a bilateral lesion, bilateral testicular undescent, you will have a higher chance of infertility, and malignancy, as you said, you can have early detection.